All right. Hi, everyone. On the another session of the handbook. All right. I really wanted to have everyone here with me today, but my voice is very nasally and my throat hurts and my nose is really blocked, so it's very hard for me to have a session with almost all of us in the group. Therefore, I'm recording one of the handbook sessions for you guys. So let's dive straight into it. Of course, if you guys have any questions with regards to the case that I'm discussing today, feel free to drop me a text. We will definitely discuss it in our next webinar together, or you can put it in the comments section as well, and I will look at it and I will reply to it accordingly. All right, so let's take a little begin. So today we will be doing condition number 77. It's a pediatric case. I feel that many of us, we do spend a lot of time studying med surg cases, and we tend to neglect pediatrics because pediatrics is not a very big cluster. It's quite small. We leave it to the very end. And the good thing is that pediatrics is actually a very easy scoring station if we know what needs to be covered. If we always approach in the terms of causes, complications, and red flags in every single station, we will be able to cover key points in the cases. So we'll do a very quick pediatrics case. It's been a while since we did pediatrics. So as we look at the case, we will also look at another version of the recall that comes very similar to the handbook case. We will look at the RCH clinical guidelines. We will take a look at history structure in pediatrics and see how we can add key points and value add to what we already know. So have a little read on this particular case. This is the case that we are doing today. So it's a 5-year-old boy. Okay, let me give you a couple of seconds to read first before I start breaking it down for you. Now, let's break it down together, all right? So if you do notice in this particular case, you do understand that it's a pediatric case. So let's take note on how to look out for or what to look out for when we are looking at a case. So for those of you who are new to AMC Clinicals, new to the handbook, it is okay to take time. It is really all about quality over quantity at this point in time. So when you look at a case, there are a couple of things that should immediately stand out at you. And a lot of us tend to use the older cases from either what other candidates have shared, and those stems are actually very short. However, if you do go into the exam, you will realize majority of your cases are not as short as you are familiar with. And also, the cases are long enough, it requires you to take time to read it. And if you do look at the task, I'm sure many of us are very familiar with, oh, history, diagnosis, differentials, that's it. But when you start reading the task, you realize there's more things that you need to do in a particular case. So let's take a little look at the stem here first. You have a 5-year-old boy, okay, pediatrics case, child is having a fever of 40 degrees, so fever high. Now you move on. It's an acute presentation of fever because it developed overnight, right? He also has an intense sore throat. And this sore throat is causing this patient to have difficulty while swallowing food and fluids. So although he's able to do so, so it is painful, but he's able to do so. So what is so unique about this thing is that yes, he's finding it painful. However, it is not that he can't swallow food or fluid, which means the minute you see somebody struggling to swallow food or fluid, you need to start thinking of, is my patient dehydrated? Is my patient still hemodynamically stable despite all of this? Can my patient still breathe? Can my patient still eat? These are things you need to start thinking about when you see such a case. Now, if you go deeper, I've highlighted the task in different colors. So let's look at what are the key things these tasks is asking us for. So you need to do a clinical exam, which means you need to ask PP from examiner. It's asking physical examination from examiner task, essentially. So clinical exam that you would perform to diagnose the problem. Examiner will then give you the results of the PE that you choose to do. So very straightforward, typical PV task is here for you. And then you realize you have a investigations task. So after you do your physical exam, perhaps it might not be enough. Okay, what you have might not be enough. Therefore, you would need some investigations to help you out with your diagnosis. And in this particular case, you are also required to give your diagnosis. And you are also required to give your management. It sounds like a very, very big time crunch station. However, if you do allocate about 2 minutes for each particular task, you should be able to finish your station. And if you do notice in the previous slide here, you do not need to take any history, which means in this task, when you're asking for your clinical examination and investigations, they need to be so strong, so powerful that it shows the examiner all the differentials that you are thinking of while you are asking for it, and it also helps you come down to a diagnosis. Now, this is the other slide that I want you to look at. These are things that you need to think of. So you look, task number one, you are telling to the examiner. Now, task number two, you are telling to the parent. Task number three, you are going back, you're still explaining to the mother, the parent as well. Now, in the AMC, once in a while, they do switch things up for you. If you look at the handbook and you look at the task, there are times where you will talk to the patient, talk to examiner, and then go back to patient, or it's patient, examiner, patient. It can get a little confusing, and you must understand the way you ask for things to a patient or to a examiner is very, very different. When you are speaking to the examiner, you can use medical jargons. In fact, you should use medical jargons when you're speaking to the examiner. However, of course, when you're speaking to patients, you have to simplify concepts, symptom them instead of telling them, oh, do you have this diagnosis? Oh, are you having a heart disease? For example, that's a patient will never know if they're having a heart disease. You got to break it down into symptoms like, oh, are you having chest pain? Oh, are you having palpitations? Maybe even check out a few cardiovascular risk factors. If you want to ask someone, are you having heart disease? Someone would never know the problem they're having until, as a clinician, you ask for symptoms. Now, so these are all things you look out for in a station. Look out for symptoms which you have, your history of presenting complaints. Look out if it's a med search or adult case. Look out for what task is expected of you. So you need to understand that if you do not answer a task, you do not fulfill a task in the AMC clinicals, very high chance that station will be a miss. It wouldn't be an easy passing station if you miss a task entirely. You also have to take note, who are you speaking to in every single task? Sometimes anxiety takes over. We become a little bit stressed and we actually forget who are we supposed to be speaking to. And honestly, sometimes speaking to the examiner is a little bit more easier, right? Medical jargon, everything is a little bit more easier than trying to find different words to explain a medical jargon to a patient, right? So now that we have broken down this case together, okay, the other things I need you to pick out is, how deeply am I supposed to answer the task? So if you look, okay, first task is asking you to indicate. Indicate means just to tell, just to mention. I'm not asking you to explain. I'm not asking you to discuss. But if you look at task number two says discuss with the parent, which means it is not indicate, it is not mention, which means you can't just touch and go. You need to explain a little bit more, a bit more of discussion on the kind of investigations you might feel that are necessary in this particular case. And if you look at task number three, it says explain. Now, explain and discuss, well, they're very much similar. They are both words where you have to take the case a little bit more in depth. So you got to explain a bit more clearly on what kind of other things that you'll be doing and what kind of management you'll be taking for your patient. And if you look at the word suggest, suggest means just to tell them, hey, we can do this, 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 this. These are options that we can do. This is what we have. So again, it's very much on key pointers. I'm not asking you to discuss the management. If it was discuss management, it means you have to go very much in depth. If it suggests, it's just giving them pointers on what the management can be. So only if you look at the handbook will you able to identify how AMC Clinicals uses different words to kind of show you the depth of how you should answer every single task. Because I think many of us struggle with, oh, how much am I supposed to say? What am I supposed to say? Right? But reading the handbook will help you identify how much and what are the options that are out there for you. Right? And one thing to understand, the handbook is the answers that has been given by AMC itself. It is the closest that we have as IMGs to the AMC clinicals. Therefore, very, very, very highly, I'm sure you guys know by now that I'm a very, very big advocate of the handbook. And definitely my goal is to do all the cases, upload them up on YouTube so that it's up there for people to look around for a very long time. Of course, I'm still trying to find the time to do it because doing a case is just not about me doing it for the sake of doing it. When we do a case, we need to break it down all the way to the bottom. We need to see different perspectives of it, see what is needed from us. We need to check the updated guidelines, see how can we adapt this case to 2025 and 2026. Well, 2026 is around the corner as well. Now, for those of you who are watching, of course, Happy New Year, because today is actually 30th December. All right. Now, let me take you to the handbook itself to read a little bit more about this particular case that's up there to identify what is required of you. All right. So let's go to the handbook. Now, so when you open the handbook, some of you guys might not be very familiar with the handbook, so let me just show you. So usually in the handbook, there's a section called performance of or the condition and the explanation of it. And there's another page which will show you just the task, the exact screenshot that I showed you in these slides prior to showing you the slide that we have here. Now, every condition or every performance procedure will show you or will tell you what is the aims of the station. So what does AMC actually want from you? Now, in this particular case, your job or your role is to be able to diagnose, okay, and to treat a child with tonsillitis, most likely group A beta hemolytic streptococcus, your guess, infection, okay, and some investigations to confirm. So you need a confirmatory diagnosis, a gold standard for your guess A infections. That becomes very important. And if you are role playing, so the handbook is just not about reading. It's about role playing with somebody else. Because when we end up reading the handbook, we're like, oh yeah, I know this, I know this, I knew this. However, when you start role playing, that's when you find your gaps. That's when you find, hey, I should have added that in. Why did I not add that in? Right? And a lot of times we think we know. When we start talking, we're like, oh man, how did I forget that? Therefore, please role play. And if you are role playing with your role play partner, get your role play partner to pick a case. Now, before you start, you read the stem, like the way I showed just now in the slides. And then your role play partner will then be reading this entire section here. So in this entire section, why do I love the handbook so much? Because it tells you exactly, all right, what information each and every individual have to know and will know and have to ask in this station. So the examiner will advise the parent as follows. So your role player, who is the parent. Now, one more thing to take note, yeah? In your in your pediatric cases, you will not have the child with you in the station, all right? It's very, very difficult to have a 6-year-old child or 5-year-old child role playing consistently for every single doctor that comes into the station. Therefore, all of your pediatric cases in the AMC will only have the parent in the case. However, every question you ask, the parent will be able to answer without any difficulty. So please do not hold back questions because like, how will the parent know about this? You know, the child is the one that will know. So please do not doubt that. Many of you guys hold back your questions. Again, this is a talking exam. If you do not ask your questions, the examiner will never know what you're thinking of, right? So this is the information the role player will know. So I'm a 5-year-old boy. I'm a mom of a 5-year-old boy. I got unwell overnight. Okay. Same thing. So very similar to what the stem has. Yeah, the sore throat, the difficulty in swallowing, and he most likely has acute tonsillitis, and it needs to be treated with penicillin. Okay. The candidate, let's get another color for this up. The candidate may suggest basic investigations to confirm the diagnosis. Okay. So which means you are low-key expected to identify and know the gold standard of your guess, a infection. The parents are also given a little bit of family history, even though this station specifically says no history required. But every role player will know what kind of character they need to bring forth to your station. Okay, and these are additional questions. So for example, if you are doing your counseling and management in this particular station, and let's say you did not tap on key points, the role player have a particular set of questions that they will need to be asking you in the station. All right. So a good way I always tell candidates is that if you are doing management cases or counseling cases with no history, it is always very good and nice for you to very quickly ask the role player, is there anything you'd like me to elaborate or clarify before I start? In this way, what happens is that you are getting the key point from the role player earlier, even before you start your station. Because you see, if for example, if you've already done all your questioning and asking, now you're left, let's say, the last 30 seconds, and then you go, oh, is there anything else you'd like to know more? And let's say now is the only time you are giving opportunity to ask a question, you will have no time to answer the question anymore in your station, and time will be up. And if that happens to be a key point or critical error, unfortunately, the station will be a miss for you. Therefore, try to identify patients' ideas, concerns, expectations earlier in your stations and not too late last minute until it doesn't give you enough time. Now, let's go back and look at the task again. Okay, some of us might have forgotten the task. Let me just bring you to the task a little bit. So, the first one is to indicate clinical examination to examiner. Second one is to discuss investigations. And then we have the third one on explaining diagnosis and suggesting management. So let's take a little peek on the clinical examinations and basically asking physical exam from examiner task. So if you look here, examination findings to be given by examiner to candidate on request. If you don't ask accurately or correctly, you will not be getting the answer. In this case, once you know that your patient is having a history of presenting complaint of fever, okay, fever and sore throat, most likely you are going towards an ENT concept. But if someone comes to you with fever, pediatric cases come to you with fever, you cannot forget your red flags. Red flags are very, very important. It shows the examiner that you are actually a very safe doctor. Right, so if you look, when we focus on the sore throat, of course, we're going to do our ENT examinations. If sore throat is positive, please spend time asking a little bit more. Is there exudate present? Okay, exudate not present. Okay, all of this needs to be asked in your station. You would definitely ask about lymph nodes. You have an infection going on, so you would have tender cervical lymph nodes. Now, let's say we want to take this step a little bit more further. You can go if you want anterior lymph nodes or posterior lymph nodes. So for anterior lymph nodes, we all are very well aware that anterior lymph nodes means that it is a bacterial infection going on. And if it's a posterior lymph nodes, then that's most likely a viral infection that's going on. This will make your station sharper when you are doing it, especially when you're asking your PP. The examiner will also be really excited because it shows that you know your concepts very, very well. Now, if you do ask questions about the tonsils and the oropharynx, a picture will be given. Now, AMC, well, as much as they're really nice and they try to help you to pass here and there are times where there are traps set for you to see how clear, sharp you are in your station. So only if you ask for a picture or how you want to see it, that's when you will get it. So even for rashes, if your patient, for example, comes with rashes, please, please, please ask for a picture of the rash or description of the rash. The examiner will give you a picture. So let's take a little look at the picture here. So this is the picture that you would be given. Okay, this is the picture that you'll be given. Of course, this word won't be there, definitely. You'll just be given the picture. They're not going to give the answer away to you. So let's go back a little bit to the other examination findings you would need to inquire. So we did mention a little bit more. If a patient comes to you with fever, you need to rule out meningitis. Biggest red flag. Meningitis, meningococcemia. Of course, I need you to check for neck stiffness. Okay, you are thinking of a possible EBV, definitely. You need to go for your hepatosplenomegaly. You are thinking of rashes when it comes down to meningitis, or you wanted EBV, your amoxicillin-induced rash. Maybe mom gave something. Maybe there's rashes. All of these concepts need to start coming to you, okay? Especially in a sore throat case in pediatrics. Now, you also want to check the temperature. Of course, this is your normal general appearance and vital signs. Vital signs are very important. Now, this thing doesn't really quite show structure, but we will talk a little bit more about PV structure, or you can refer to PV structure in the previous YouTube video that I uploaded. All right. We also want to look at how you also do a very quick otoscope examination in your exam. If you do, well, of course, in your examination, you might do a little bit more than this. Definitely. A lot of us want to be very thorough. However, be considerate over the time that you have. All right. And also, as long as you finish the basics, you do your ENT exam, you do lymph nodes, you rule out meningitis, of course, with your vital signs, you should be done. Good enough to proceed on to the next task. So this will take you about 1.5 minutes. So very easy, very flexible, comfortable time management in your station. Now let's go down a little bit more. So the other reason why I love the handbook is because they tell you exactly the expectations of you in the exam. So the expectations of candidate performance. So what is required of you in this station? All right, so let's take a little bit of a look here. Yes, important for you to know the clinical findings. Say once you do a very good physical exam, you would be able to identify its acute tonsillitis and most likely bacterial, definitely. Now, well, you could consider doing a throat swab to confirm prior to antibiotic treatment. You should also be able to explain in simple terms the diagnosis and its associated complications. Every time we try to explain a diagnosis, it is very important that we know how far or what is the cause of the disease, what is the cause of the condition. So what do I mean? How is this condition going to turn out if I don't take care of it, or if I don't take care of it enough? So for example, let's take something more simple like diabetes, right? Someone can have diabetes, but what happens if maybe the amount of medication you give or the sugar control is not as fantastic? So yes, they might be very compliant, but insufficient insulin. Let's say insulin levels are insufficient. Now, what kind of complications patient can have? So you think of your retinopathy, you think of your sensory neuropathy, you think of healing that takes a very long time. Only if you ask these questions to your patient will the examiner know that you are actually thinking about them. However, in this case, let's bring it back to this case, so there's no history. So all of this will come under explaining to the mom. Now, when it comes to an acute tonsillitis, of course, your biggest worry is your quinsy. The quinsy is a very, very big worry. Again, think back on key questions or key pointers and key explanations of quinsy. We usually use hot potato voice or muffled voice. Okay, I'll very quickly show you guidelines from RCH. Okay, now very quickly show you guidelines from RCH. So here, this is guidelines for RCH. Okay, usually your guess A infections. So let's take a little bit more. So when you look at your RCH classes guidelines, I really love it because it really tells you what would have been important, key points you would have needed to take in your history. And if you move down, you have a little bit more on the examinations. What are things I need to have look out for in my patient's case? So yes, we talked about hemodynamic stability and dehydration previously, especially in a sore throat. We talked about fever. We talked about an ENT examination. We talked about tender anterior cervical lymphadenopathy. We spoke a little bit about your hepatosplenomegaly, as I showed you just now. And if this now someone having Gase infection, all right, and now when it starts surfacing on the skin, the toxins start surfacing on the skin, now that becomes your sandpaper rash. It becomes your scarlet fever. So very similar conditions. Again, it shows the cause of the disease of a Gase acute tonsillitis case. And this is something that all of us should be very familiar with. And let me show you why we should be familiar with this. But before we go on, these are red flags you need to take note of in a sore throat scarlet fever case. Okay, as we talked about, would be hot potato voice with your quinsy. You want to talk about your drooling and your tripod position, again, for your epiglottitis in a sore throat case. Okay, of course, the rest pretty much goes on to respiratory distress, hemodynamic instability, and neck stiffness cannot be forgotten at all. Now, let's go back to the case and let me show you another case that we have. So I will be discussing management in a bit after I show you the other case that we have. Okay, so let me just show you the other case in a bit. Okay, now this is another version of the case. Have a little read. Now, this will be a common one that many of you guys might have seen in the exams. It comes up once in a while in the exams. Very popular common case. All right. So now this case comes with history. Physical exam will appear on the screen. So good, you're lucky here. You don't have to ask for PP. Fantastic. And again, diagnosis management. So you see very similar. Okay, very, very similar to the previous one. So the previous one was without history. This is with history. So before I show you the P card and all of this, okay, let me run you through structure in pediatrics. So typically in pediatrics, you do a very good history of presenting complaint. You will then do your associated symptoms, you rule out your differentials, well-maybe questions, and Bind's typical standard structure. But you need to know where to emphasize importance when you're doing your cases. So the particular case that we saw, now, fever and rash was given to you in the stem. Of course, mom was worried about meningitis. Definitely, we'll look into that as well. Other symptoms you would have caught would be sore throat and lymph nodes. But presenting complaint is fever and rash. So please spend time talking about the fever and rash. Give it enough importance in your history of presenting complaint. The fever, go with when did it start? How long? Sudden? Gradual? Is it going up? Is it coming down? Did you measure it? Did you try something for it? Did it work? Whatever you tried. Now, a lot of candidates just very quickly go, how high is it? When is it? What did this go straight for? The medication you gave, did it work? So they assume that medications was given because candidates are so excited to rule out Kawasaki. But you must understand, if you go straight for telling the role player, oh, did the medication work? You are just checking and assuming. You need to start with the concept of, was there anything that you tried for the fever? Only if you ask this open-ended question will you be able to catch the fact that, oh, it could have been an amoxicillin-induced rash because of a misdiagnosis, because it's an EBV and the reaction is what gave you the rash. So that is a concept that could come up. Therefore, open-ended question first is, did you try anything for the fever? Or have you tried any kind of medications? If it's a yes, follow up, follow up. If it's a paracetamol basic, okay, did it work, did it not work? Again, how much did you give? Of course, all of that needs to be checked. Now, when it comes to rash history of presenting complaint, a lot of candidates, yes, we ask about the distribution, fantastic. But a lot of candidates start running to asking about, oh, is it itchy? Is it painful? Is there vesicles? Is there discharge? But you must understand that rash has its own set of primary features and then secondary features. Itchy, pain, vesicles, discharge all fall under secondary features of a rash, right? So please start with distribution, okay? Morphology, shape, color, texture, blanchability. Now your blanchability question will be, oh, mom, if you press on the rash, does it change color? Right? So those are your good questions to ask about blanchability. So spend time with the complaint and then go on to secondary features. It shows the examiner you very clearly know what is primary and what is secondary. Also, when you have more than one symptom presented in front of you, it is very, very, very important to ask the relationship between all of them. Because there is a possibility in this case that this might be a malignancy case. So sore throat and lymph nodes is something that you identify through your history taking. Fever and rash is given to you initially. So it could have easily been a leukemia case, okay, or a lymphoma case, most likely a leukemia case. And what's happening is that the fever is happening because of the immunocompromised state, right? Because, oh, doctor, the fever has been going on for the past couple of months, doctor. The rash just appeared. Now, this is going to ring a bell. So you cannot assume that all of the symptoms came suddenly and came together. So the more symptoms you get, please start identifying if all of these symptoms came at a similar timing, which came first, and how severe they all are. So you have to rule out meningitis in this case once you see your fever and rash together. The minute you see sore throat, Yes, you can ask a little bit about your sore throat, but you need to check on dehydration status. So is my child hydrated well enough? You need to rule out your quinsy and your epiglottitis. Once you get your lymph nodes positive, please spend time anterior, posterior, tender, non-tender, mobile, not mobile. All of these needs to be explored very, very well in your station and not just running down a list of questions in your case. Okay, so now let's take a look at the critical error, not the case that we just saw, but the handbook case. Now, the critical errors in this case are for you to not even consider a streptococcal tonsillitis or not knowing a tonsillitis might not allow you to pass the case. And if you're not able to know how management is done in the case, you might also not clear the case. In this particular case, you need to be able to identify the physical findings you get. So identifying is one thing, but understanding it is another thing. Interpreting the examination you ask for is a different thing, right? Of course, an interpretation also comes the fact that they're giving you a picture to understand the case. Okay, to know, they're not asking you to know everything about the treatment plan. Of course, in the ideal world, I would love you to know everything, but I know it's very, very difficult. Okay, therefore, a little bit touch and go, enough information, the key points at least, and a decent explanation both to examiner and to the mom. Let's have a little look back on the management. So we're going back to the guidelines. We're going back to the guidelines to check the management. All right. One thing to note is that the handbook is published in 2007. So as much as it's a very lovely, amazing book, I still love it very much. Please do double check because it's 2025, 2026. Now we're entering 2026. Many things might have changed. Okay, so please take a look at those. Now, this is your management for a typical sore throat case, but I want to bring you back to a little bit on scarlet fever. So, if there are signs of scarlet fever, for example, which means you are thinking your patient has your sandpaper rash, okay, also has your sore throat, lymph nodes anterior, everything positive, you would consider performing a throat swab. Throat swab is your golden standard, okay? You would consider performing throat swab, starting empirical antibiotic therapy. So let's spend a little bit of time reading on the antibiotic therapy in a bit. And of course, supportive management. Very, very, very important. A lot of candidates tend to forget that in your stations. Okay? So let's go. So throat swab is not routinely recommended. That's one thing. So we're not going to do a throat. Just because you have a sore throat doesn't mean I'm going to do a throat swab. However, if you have signs of scarlet fever, like your sandpaper rash, yes, I would then consider performing a throat swab. So be very careful with that. Okay, be very clear on that. Now let's go for treatment management. So of course, supportive ones, very basic. We're going to do analgesia because it's definitely going to be painful for the child. Hydration as well, just a little bit of fluids. You can ask them to put like orange juice and ice cubes and then just maybe suck a little bit on that. That's a very fun one that kids used to like because it's very colorful as well. Apple juice frozen, orange juice frozen, or watermelon juice frozen, and just suckle on it a little bit. That's very, very nice. Now, corticosteroids only if it's severe pain and even if your basic analgesia, okay, your basic ones are not working, then you go for it. Now, let's go for a little bit more on the antibiotics aspect of things. I want to spend time on the antibiotics a little bit. Now, for the antibiotics, empirical antibiotics, okay, is not recommended for everyone presenting with a sore throat. Just because the patient comes with sore throat doesn't mean you quickly give antibiotics. In a scarlet fever case, only if you start having signs of scarlet fever, then you consider your antibiotics. Now, I need you guys to remember this for me. Phenoxymethylpenicillin, cannot remember the whole thing, penicillin, safe enough. Now, every time in the case where you don't have a history and you need to give management of medication, I would love you to say that after ruling out allergies and contraindications, I will then be prescribing you with phenoxymethylpenicillin. Okay, I would love to give that for you for 10 days, twice a day. If you can't remember the dosing, no problem. Try to remember the 10 days. The other thing I need you to remember is this. I know your child might be having a sore throat, might be hard to swallow. If it's very difficult, we can consider an intramuscular single dose injection. Okay, but however, if they're tolerable, we can then consider oral. So show the examiner you're not just there to throw out the fact that you know the antibiotic name. You care about your patient. You are thinking about this case holistically. Okay, tailor making your management and pharmacological management for your patient. That is very, very important. That's how you score extra points and keep yourself above that 4 in your stations. Of course, if there's allergies given, you would think about other kinds of antibiotics, but no worries. As long as you remember your phenoxymethyl penicillin, good enough in your stations. 10 days, good enough. If you know that it's about 15 mg per kg and you can do the math, fantastic. I struggle with doing very quick math, therefore, as long as I usually just say 10 days, 2 times a day, and then I leave the math for the calculator to do it, okay, and the pharmacist to do it. Now, if you do get suppurative complications, like your quinsy, these are the management to go for that. So please refer to clinical RCH guidelines, okay, to learn a little bit more about what kind of things you can look out for. Okay, and it's a very, please spend time reading the guidelines. You actually learn a lot. It's really, really amazing. Okay. Now, again, I've always shared this in most of my sessions. All right. AMC Clinicals is always looking for you on how you get to the diagnosis. Not about the diagnosis, but the way and process, the way you think. The diagnostic formulation is way more important than the diagnosis itself. So please do not memorize questions and memorize and ask things for the sake of asking. I need you to understand the reason behind every single question that you have. And of course, AMC, in fact, any hospital, any kind of licensing exams will require you to be a safe clinician. I can't have a doctor who does not ask me any red flags in my station because you are not checking for worst case scenario. As clinicians, it's very important we identify worst case scenario. We catch things early so we can solve the problems. And the idea of holistic approach is this, it's just not about the problem, right? It's always a bit more extra. So you got to look a little bit more at the support system, a little bit more at the family, a little bit more about mental health. All of these things are important. They value add to your cases. But of course, basics first, and then do your value add. You must understand there are 40 candidates going for the exam on the same day as you. Same cases, same 16 cases everyone is going to have. The question is, what is going to make you different from the candidate beside you? Okay, and the other candidates in that exam on that day. Are you just going to follow a structure blindly, or are you going to understand the reason behind it and value add and bring your personality to the exam? Okay, that's very important for you to know and think about. This has always been my favorite quote that I end. As much as we work very hard to study and there are a lot of struggles, well, the end of education at the end of the day is character. Who you become out of this studying, your character development, the strength that you get, the discipline, the resilience, the belief in yourself, the trust that you get on yourself is actually the most beautiful thing out of all this that these licensing exams that we do. Well, right now when you are studying and you know the exam is just a couple of days away, it might not seem so big, but the bigger picture is still being happy, having a happy family life, all right? Fulfilling your goals and dreams, always looking towards a growth mindset. Okay, that's still something I always, always, always advocate for. Okay, so if there are any other questions, please put them in the YouTube, the comment section down below. Drop me a text, I will tackle them in the groups. Okay, so thank you very much.